Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, everyone. Welcome to another episode of the AOMPT podcast. My name is Dhinu Jayaseelan, and I'm pleased to be joined by Dr. Antonio Varela. Dr. Varela is an assistant professor of physical therapy at the Arkansas College of Health Education Physical Therapy School. He completed his bachelor's in physical therapy from the University of North Florida, his DPT at the University of St. Augustine, where he also completed his fellowship training, and his PhD in human behaviors from Capella University. Today, we'll be discussing his recent publication in BMC Musculoskeletal Disorders titled The Relationship Between Psychosocial Factors and Reported Disability, the Role of Pain Self-Efficacy. Dr. Varela, thanks so much for joining me today.
Well, thank you, sir. Thank you, Daniel. I appreciate it. And I think this is an honor to be here. I look forward to talking with you.
I think one of the things we have to start with is in recent years, there's been a lot of discussion on pain and neurophysiology. And with that comes a lot of kind of buzz terms. And to me, pain self-efficacy seems to be one of those terms. Before we get even into your paper, do you mind kind of giving us a more specific definition or kind of working definition of what self-efficacy is actually referring to?
Well, that's a good point, particularly in regard to buzzwords. And I think what makes them buzzwords is that there is a working definition that sometimes becomes difficult to translate into a clinical situation. And self-efficacy and pain self-efficacy is one of those words, right? So we understand it as a level of confidence of being self-efficacy by itself. When you start referring it to pain self-efficacy, then we have to wrap our mind around the idea that it's related to pain behaviors. So I break it up into two definitions. There's an academic definition, which is or revolves around the individual's beliefs about their ability to control pain and any of the associated emotions, dysfunctions, work-related activities, healthcare disparities, and to appropriately utilize any pain strategies that have been provided. So that's the academic definition. I think my anecdotal definition, based on my history and the literature, is that pain self-efficacy is really the opposite end of the spectrum of fear of pain or those pain-related fear avoidance behaviors. So, we're driven to experience pleasure as a whole and to avoid pain. That part's normal for us, but there are times that we have to face the pain. And pain self-efficacy is our ability and confidence to do that. So, again, I think it relates to a person's ability and the way that we teach them as physical therapists to face pain, control pain, overcome pain on a day-to-day basis. I also think it's important to identify what pain self-efficacy isn't, right? So to me, it's not positive psychology, it's not optimism, it's not grit, it's not outcome expectancy. It really relates to inner beliefs and inner confidence. Does that make sense? Does that help?
Yeah, it does. Because when we start to think about self-efficacy, a lot of connotations can come into it. And so when we're kind of honing in on the confidence and the ability and perceived ability to do something or not to do something, I think that really kind of guides us in how we're starting to think about pain self-efficacy in terms of evaluation and then management. And that's what you did in your study is you kind of started to try to associate pain self-efficacy with a number of different variables that we see in chronic low back pain. And so can you give us a recap of maybe what your study looked at and what you found?
Yeah, absolutely. I get excited about it, so I might be able to ramble on a little bit. Let me know if I go too far. So just to be clear, it was a cross-sectional analysis. And I looked at the relationships between specific psychosocial factors of catastrophizing, depression, fear, pain self-efficacy, and how they related to a reported disability. The population was non-specific back pain, low back pain. And really what I was looking at was the relationship between the individual relationship, that is, between fear and disability, catastrophizing and disability, and depression and disability, and how that relationship changed when we introduced pain self-efficacy. So what ended up happening was we identified that there was a direct inverse relationship between pain self-efficacy and reported disability. And that once you introduce pain self-efficacy to the relationship of reported disability to those other specific psychosocial factors, that their relationship fell apart. So in other words, there seemed to be on a statistical level a mediating relationship between pain self-efficacy and the specific psychosocial factor with reported disability.
Even though we kind of could have predicted that outcome, it's good to know that that's kind of supported in a way by evidence, because we kind of think about, pain that's been going on for a long period of time. People might have less confidence, or we think about the relationship between depression and self-reported disability, and then how pain self-efficacy might have affected that. And so we kind of could have guessed that based on our clinical experience, I think. But we can never assume something's going to happen just because we've seen it in the clinic. So it's good to see the support with research. I'm wondering, did any of the things you found, anything surprise you?
I do want to say, I completely agree with you. There is an inherent understanding that these psychosocial factors influence the disability and the reported disability. And inherently, we would understand that pain self-efficacy, it is inherently going to help the situation. Where I think the research comes into play is we begin to work out the nuances of these relationships and where we might focus. So the beauty of my research, I think, is it establishes a baseline. It is a correlational study, and causation, of course, is difficult to relate to the study. But statistically, the numbers were so strong that I'm comfortable saying, from a theoretical perspective, yeah, pain self-efficacy mediates those relationships. Now there's a responsibility to follow through, not only with my own follow-up research, but with other people out there. I hope that we start shifting away from the idea of fear-related stuff to how does pain self-efficacy actually change those relationships. So to answer the question, though, nothing really surprised me, but there are some factors that I'd like to highlight. And one of them goes right back to the inverse relationship between pain self-efficacy and reported disability. It was almost a one-to-one relationship. For every single point that goes up in self-efficacy, there is a point that goes down in reported disability. So that finding, to me, speaks volumes as to the importance of pain self-efficacy. Now, we did have to adjust for pain and age-related factors. So in the end, I think it was really more like a 2-to-3 relationship. So for every 3 points that pain self-efficacy went up, there was a 2-point drop in reported disability. And then there was another factor too. So when we look at the pain catastrophizing scale, it can be broken up into 3 different categories: rumination, magnification, and hopelessness. So as a side note to the study, I was hypothesizing that hopelessness would have a stronger relationship to pain self-efficacy than it did, but it didn't. All 3 of those had an equal relationship. Now, that wasn't actually reported in the study that got published, but that was background work that we did with the statistician to see if there was another avenue to go here. And the thought process behind that was, if there's a sense of increased hopelessness as a direct relationship to pain self-efficacy, would that bridge over into levels of depression? So again, to answer the question, there was nothing that really stood out from the study that surprised me. It went according to the hypotheses. And again, that goes back to the intuitive nature of it all.
I think you bring up a good point, is that there's this intuitive nature to clinical practice, and I think that should not be discounted, but the research really helps to identify and understand the nuance related to our opinions and our beliefs and all of those things. And you also mentioned, and I completely agree, that this is a correlational study, it's cross-sectional, so we can't understand causation at all. But that being said, it's always interesting to kind of think about which came first. Was it low pain self-efficacy that led into higher levels of depression and higher levels of self-reported disability? Or was it the persistence of pain and depression that led into worse pain self-efficacy? I know that we can't find that out based on your study, but I do think it's probably relevant to try to understand, did one lead to the other, because that can start to work through research for prevention and maybe treatment programs. So do you have an opinion on if it's like a one-way relationship, or is it just too hard to tell, do you think?
Well, I think the philosophy of the chicken or the egg scenario has been figured out, right? So there had to have been a genetic predisposition in the egg in order for the chicken to arrive. However, some people will argue that the chicken or the egg scenario really depends on whether it is breakfast or dinner. So I think in the end, it's a mixture of the two, but I do have a parallel thought process. First, we have to understand that self-efficacy is a component of resilience. And I would like to assert that we are born with an inherent amount of resilience. Resilience actually leads to an ability to adapt. And that inherent resilience is either enhanced or diminished as we develop. So the implication is that self-efficacy is also enhanced or depleted through our formative years. So to me, there is an underlying argument that self-efficacy is something that comes into the picture beforehand, particularly if we have higher levels of resilience that have been part of our development and have been enhanced as part of our development. What that really means to me is people who have increased self-efficacy as a component of that resilience learn to negotiate life and the potential stressors with greater efficiency. Yeah, so I'm implying that people with increased self-efficacy are adapting preemptively or in real time as a component of their resilience. So I think there is an argument, a substantive argument, that many of the people we see had a greater compromise in their self-efficacy and their resilience that led to the development or the perpetuation of chronic pain. There are things that happen throughout life that actually help build our self-efficacy and our resilience at the same time. And of course, that's enhanced when you have a better team and a better environment and a better family situation around you.
And I think that part goes unnoticed a lot of times when we get into clinic and when we start to think about management and teaching the management of people with low back pain, is the risk factors for persistent or chronic musculoskeletal pain. A lot of them have very little to do with physical impairment. And so a lot of them have to do with things like tenuous housing situations and stress and physical and maybe history of sexual abuse and things like that don't always get picked up in your subjective of why is your back hurt, And that's a lifelong process that leads into how people are perceiving or managing their symptoms. And some of that is modifiable, some of them it's not. But I think it needs to be addressed, which I think makes this kind of work so much more important. In your work, specifically your study, you all looked at adults with chronic low back pain. And when you look at the research, I feel like the definition of chronic can kind of be arbitrary sometimes. Sometimes it's pain that lasts longer than it's expected to persist, which I think is an arbitrary and kind of ridiculous statement, because how can we say pain is not supposed to be present? But then also some studies will say it's anything more than 3 months is more chronic versus acute or subacute. Again, going back to assumptions, I feel like people that have had pain for a longer period of time, that maybe have tried different things intervention-wise, and their pain still persists, it hasn't gone away, and it's impacting their day-to-day routine, their ability to perform different activities. That person with that kind of pain, it would make more sense to me that they feel less confident in their ability to manage their pain. So they would have lower self-efficacy. In terms of your study, I'm wondering, how'd you define chronic pain? And then also, do you feel like these types of relationships would be seen in the acute pain population?
That's a great question. I completely agree with you, Dhinu. The defined time frame for chronicity is completely arbitrary, and I think the most consistent definition is somewhere around 3 months. Just to be clear, with the study, the patient population was non-specific chronic low back pain, which I think throws in another dimension, because I was just about to say that chronic pain to me is the pain that persists beyond the tissue healing timeframes, and where we know or have evidence that the tissues have healed. But in many cases, these individuals didn't have any significant tissue disruption. But I also think it's important to include pain behaviors, the disability convictions, and compensatory patterns. And if you relate that to acuity, I think you can see some of that, meaning pain behaviors, disability convictions, and compensatory patterns, particularly in the non-specific levels of pain. But you'd also see an increasing or very more prevalent psychosocial overlay. And I think that goes back to part of the previous conversation in regard to the social dynamics of that individual.
I agree that there's a lot to be done here, especially when we start to think about in this group of people that don't really have a tissue injury. How do we start to put these labels of is it acute or chronic on those people? And then we also know that labeling can be really detrimental in general. But regardless, if they had acute, chronic, subacute, persistent, whatever you want to call it, whatever kind of pain they have, if somebody has poor self-efficacy, what are some ways we can try to enhance that? What are some ways we can try to improve pain self-efficacy in that person that needs some help?
Well, now we've gone full circle, right, with the idea of how it can be a buzzword. And this is where the challenge comes in. How do you apply? I mean, there's these recommendations out there, and I'll get to that in a moment. I do think it's important. I really want to emphasize this point. We have to recognize that this is a personal journey, right, within ourselves. So, I mentioned the idea that we're born with an inherent amount of resilience, and which comes with an inherent amount of self-efficacy. But none of us are 100% self-efficacious across the board. And all of us are striving to become better people. I think part of my journey has helped me to discover this research and the upcoming research. So I think if we start with that context, then we have a better understanding of the people we serve. And I think it leads to a level of validation that everything that's going on with them is real to them, and it's a part of their development to overcome this with a sense of appreciation for having gone through it. Looking back at the times that I've struggled, I now know, having gone through that, I'm a better person. And I want my patients and those that I care for to understand that as well, that this is part of their overall development. So I think then once you get past that validation, there has to be a realization that we are our own worst enemy, and we're the ones that set those boundaries. And as we coach people, we have to coach them and to care for them where we move them outside of their comfort zone. And I think that's the issue with self-efficacy, right? We don't know how to manage ourselves outside of our comfort zone. We don't have the confidence to see that outcome that we would hope occurs. So then we avoid it. And it's the same thing with pain. I think we have to push our patients, compassionately push them, of course, to that level of discomfort in a moderate sense, right? Now, I mean, we're throwing them off the edge, but we're definitely pushing them to the edge and having them look at the possibilities beyond the limitations that they've imposed on themselves. And I think that also requires us to impose a certain level of cognitive restructuring, which means having patients recognize their own cognitive biases and their cognitive schemas that just reinforce where they're at. And it's a perpetual state of being for them. And in some cases, I've even used things like rational self analysis, where I have had patients who say a repetitive sentence. And just to be clear, it's a sentence that I've heard them say a couple of times. I'll write it out for them and have them restructure that sentence so that it becomes something constructive as opposed to something that is just reinforcing or something negative. Most of the times, all of that is built on a set of values, meaning their cognitive schemas, their cognitive biases. So I do encourage value prioritization. I'll talk about what's important to them, and I will have them identify what values should we put on top as the values that are going to drive them. What's really interesting is a lot of the patients that I've had, they struggle coming up with those answers, and they've never really contemplated it. I mean, I find that absolutely fascinating because it's one of those things that it seems inherent to me that we would try to identify that. But to be honest, that's part of my personal struggle, right? The idea of a value-driven life. And I love to understand how other people view things and what's valuable to them. I mean, I think I get as much out of it as I hope I impart to them. Then getting back to the suggested academic approach to self-efficacy, the idea is goal setting. And we do it all too often in physical therapy with 2 weeks out, 3 weeks out, 4 weeks out, 6 weeks out. I really like that relentless pursuit of short-term goals, like just day to day. Do something today that is going to take you outside of your comfort zone and report back to me. And the idea of being reflective and journaling to try to better understand yourselves, something that I'm a big fan of is mindfulness training so that we can begin to granulate the sensations, the emotions, the values, and the thought processes that all too often drive people to stay in that perpetual circle. So all of this, I think, is pointing to an active approach or active coping approaches from the physical therapy point of view. And I think it's also highlighting the importance of the individual. There isn't a single remedy, but getting to know the individual and what they value, how they perceive their worlds and the world around them, what they're afraid of, and what limits them, and how they feel about those things, I think is important. And then setting goals to work their way out of it with the value as an underlying motivator. So I hope that wasn't a long-winded answer, but it's not an easy one, with the sense that it does require a little bit of thought and it does require a little bit of personalization.
There's not a quick answer to that question, and I don't think it should be. And the complexity of how do you get somebody to be more confident in their own skin, especially in the presence of pain that's making them have difficulty doing what they need to do, that's a challenging task. And so things like what you've mentioned is kind of restructuring what pain means and what it's perceived to be, really kind of understanding that it's okay to need some help. It's okay to not be okay. I think that's the first step. But then also, I like how you kind of mentioned that the PT's role is more of a coach versus this person that's kind of doing the work for them. That's kind of counter to the idea of improving pain self-efficacy. But also, I do think it brings up a couple of different points where you mentioned things like cognitive behavioral therapy and restructuring. And sometimes these are kind of in the wheelhouse of the PT, sometimes maybe not. One thing that tends to be present pretty frequently, it was noted in your study, is this depression with chronic low back pain. And so I think we get pretty decent at screening out, does this person maybe have depression? Like you used in your study, the PHQ-9, there's abbreviated versions of that, PHQ-2 or 4, whatever we'd use to kind of screen out depression. We can easily ask those questions. But what happens when somebody comes back and says, I am not as interested as I used to be in playing softball, or I don't like getting up in the morning and taking my kids for a hike as I used to, or things like that. Once we start to identify these kind of psychological variables that maybe need a little bit more attention, what are we going to be doing about that? How do we facilitate that person improving their pain self-efficacy if it's not with us?
Well, that's a great question. And it bridges off what we were just talking about, the idea of encouraging self-efficacy, right? They're presenting with decreased self-efficacy, which in and of itself, as the dysfunctions, the pain persists, that becomes oppressive and depressive. It's hard for me to think that those situations wouldn't be depressing. And I think what I'm alluding to is that the spectrum of depression escapes us. And some of it can be very situational, and some of it can be more sinister than that. So I think that the answer to this question begins by first discussing it and raising awareness. And I might argue that we don't screen for it as much as we should. It seems like a lot of people treat it like playing in traffic, right? So it can be dangerous to mess around with. So I think most people try to avoid it. I think it becomes inherent on us as part of our willingness to care for people. We really have to do a much better job of screening for it. And I do rely on the PHQ-2. If the patients endorse both of those questions, then we have the responsibility to give them the PHQ-9. The clinical interpretations or the clinical diagnostic process is not enough. We have to granulate the level of depression so that we can best respond to it. And I think the PHQ-9 does that. And just to be clear, we're screening for it where a primary care physician or practitioner would use the PHQ-9 potentially for the diagnosis. I think, again, the issues of depression and the spectrums of depression are really elusive, but we can do a better job of recognizing the increasing number of people with depression, if that makes sense. The other part of that too is I think there needs to be more collaboration when we are screening for that. To me, 10 on the PHQ-9 is that cutoff score where I say, okay, they need additional help here. Once you start going above 10, you're getting into moderate severity. And that is definitely not within the scope of physical therapy. But I think if we really go back to understanding our patients, and going back to understanding their values and their state of mind, where they're at when they present us, we may be able to facilitate them working their way out. Well, here's the situation, right? Like the idea of managing somebody's pain self-efficacy or just self-efficacy and their levels of depression don't really look much different as long as we're being cognizant of our limitations in managing depression, right? We have to refer out, and we should be more collaborative. And that gives a level of responsibility to the health or the mental health care providers, right? They should be communicating a lot more with us in regard to how we might be better able to facilitate that. So I know I'm giving you a long-winded answer again, but the idea is it's really not an easy endeavor. So if you go back and think about the exercise, right, there's no homogeneous activity that helps depression. And I think if you look at the neurophysiology of depression and how exercise helps that, then you probably will land on 3 or 4 different things. Aerobic activity is something I like because we just don't do enough of it. The idea of the movement awareness practices like yoga, tai chi is the other aspect of that, so that they become more aware of it. And then it goes back to the mindfulness practices so that they can begin to be more aware of their sensations, be more aware of the negative biases, and be able to granulate that in order to communicate that, not to us and to the mental health care providers. I think it also becomes incumbent upon us to point out that there can be an increased sense of savoring daily moments and all the beauty around us on a daily basis, which escapes the mind of the individual who's struggling with depression. When I do mindfulness training, if I've done several sessions of it, I will spend some time doing some savoring, like take a look at something that you think is beautiful and just appreciate it for what it is, as it is in that moment. Another long-winded answer. I'm sorry about that, Dhinu.
No, I think it's great to get your perspective on that. And it also kind of reminds me that sometimes we as physical therapists, we kind of assume because we get so much time with people that we're responsible for them and we're responsible for their return to function and we're responsible for them enjoying life again. And we forget that we're part of a healthcare team, and we're allowed to delegate some of this work to other players on this team. And we got to get other people involved, especially when there's so much complexity with this person's life. As much as we want to put on the patient to return their confidence, we also have to get them better in different ways. And some of that's not in physical therapy. And actually some of it is. So when you say aerobic exercise, I love aerobic exercise for people with persistent pain. But sometimes the person with chronic low back pain has difficulty walking still. Sometimes it's not just all this psychological burden or mental pain perception, but there's physical components to their pain too. So I sometimes think that we get so caught up into managing the perception of pain and the confidence of managing your pain. We forget sometimes there's like stiffness in your back, and maybe we could use manual therapy to reduce that stiffness so you could walk a little bit longer, or you can go up that hill because your hip extends better, or kind of thinking about those physical impairments. I think we get away from that. I've got my opinions on it. I do think manual therapy has a role to play in this population. But what do you think we could do using manual therapy? When is it appropriate? When is it not appropriate for that person with low back pain, specifically maybe with lower pain self-efficacy?
Yeah, that's a great question. If I implied that you could just throw somebody on the treadmill and have them do some aerobic activity, I didn't mean to, right? So
No, not at all. I didn't take it that way either. So
the idea of how you might deal with the issues of self-efficacy or depression, it is a build-up process, right? So again, we're not throwing them over the edge, but we certainly are having them broach these barriers that they've put upon them. And so then speaking of that, I mean, we're going back full circle again to those behaviors and compensatory patterns, which either occur because of or develop as a result of the perpetuating pain. And I'm talking about the stiffness in the back, the decreased mobility in the hips, the issues of losing reciprocating patterns. And I think manual therapy serves a phenomenal purpose for those up front to change those tissues. And then also, I give a lot of credit to my diagnostic skills through the manual therapy training and the discipline as to how you would go through an evaluation to help me with that. So, as part of the compassion and the empathy, you have to get your hands on the patient. And then, as part of the physical therapy, make as appropriate corrections as you can to those compensatory patterns and the physical impairments that exist in order to optimize their movement patterns and then wean yourself off of that, right? So the risk is that codependent relationship. And I know a lot of manual therapists want to fix patients, and we all care for them to the point that we want to fix them and take care of the issue. But now, being in this career for 20 years, I know that there's no fixing people. The best we can do is provide them the optimum physicality and the optimum set of tools for them to try to carry on their own. And I think that's why I've gravitated towards the chronic pain patients, because I think once they gain the self-efficacy, it builds momentum and they really start to work their way out of it. And again, I give credit to the manual therapy. I give credit to the breaches in their comfort zone. And I give credit to the underlying compassion and empathy in which I approach them in order for them to find a better part of themselves.
And I think it keeps coming back to the idea is we want people to have more confidence, have their ability, and have that as an intrinsic process that they don't need us to do something for them. And so sometimes I feel like it seems counterintuitive then to put your hands on somebody to try to improve their pain self-efficacy. But I keep going back to if it's going to help them feel better so that they can do more, I should be doing it. And so a hands-off approach maybe works in some people, a hands-on approach maybe works better in some people. And like you've said all throughout this discussion, it's so complex and every single person's different, and pushing them to their limit and not beyond their limit, that's got to take a lot of discussion and time and these short-term goals that you keep setting for yourself and for the patient. And so there's a lot that goes into it. And I think the first step is kind of understanding, what is it? What's the relationship? Is it present? Is it not? And I think that's so important that you're doing this kind of work. And so I really have enjoyed looking through this paper and having this discussion with you. And I hope some of our listeners will be able to kind of dig deeper into this paper and your future work. And so I'm hoping that there's more work to come.
Yeah, absolutely. I have a shameless plug here about a depression paper I have coming out. So I do theorize on the potential for physical therapists to be part of a mental health interdisciplinary team in that paper titled The Theater of Depression, the Role of Physical Therapy. It's physiotherapy because it's in the Physiotherapy Theory and Practice journal. And it really explores the issues of depression across the spectrum. And hopefully it encourages people. Currently, I'm doing a research study on chronic pain and depression, where I'm incorporating exercise, mindfulness, and guided reflection. It's a pilot study with 25 people, and I'm in the middle of it. It's a phenomenal experience for me. Like, I'm getting a lot out of it personally. Two things: the mindfulness seems to be making the biggest difference, and the guided reflection is turning out to be a venue where people just support each other. And I think it speaks to the need for us to be social, something that we certainly have diminished, if not completely excluded from our lives in the last couple years, but something that technology is also kind of robbing from us. So we sit in a circle and do the guided reflection, which is just meant to be a conversation about the experience of exercise and mindfulness and the utility of it, but it turns into much more. And there's no phones, there's nothing but us sitting there talking. And it's amazing to see how people across the spectrum, I got somebody who's 22, somebody who's 75, and they're just talking, relating to each other and helping each other out. And I am working on a follow-up longitudinal study to this cross-sectional study as well. So I am hypothesizing the same thing, right? That now with a longitudinal study, we'll see a little bit more causation.
Yeah, and all this stuff is, for me, treating chronic pain, treating people with peripheral pain primarily, but it's been persistent for a long time. A lot of this stuff kind of plays a huge role. So it's interesting to me to see the research behind it. And so I really do appreciate you kind of devoting so much effort towards this. And I really appreciate you, Dr. Varela, taking time to chat with us today.
Yeah. Well, no, thank you very much. I would like to throw it out. I would like to throw something out there as well. I would love to work with somebody on developing a mental health neuroscience education. So we see the benefits of the pain neuroscience education. I think that there is a way that we can granulate a mental health neuroscience education. So if anybody has ideas, I would love for them to reach out to me, and I would love to work on that. I think that's the next phase of our evolution in physical therapy, is to get more involved with mental health. And of course, it covers self-efficacy as well. It's been a pleasure to talk to you. I think this has been a particular highlight, and I'm grateful for the invitation and for the time that we spent together this morning.
Yeah, me as well. And so just for those listeners that are interested specifically in teaming up with Dr. Varela about this new work that he's working on, we're going to also tag in contact information to the show notes. So just go ahead and look at the show notes and you'll be able to find Dr. Varela's email. And I'm sure he wouldn't mind touching base with anyone that's interested in talking more about this content.
That's awesome. I appreciate the opportunity.
All right. Well, thanks so much. We'll talk to you soon.
Okay. Take care. I look forward to talking to you again.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT. The views and opinions expressed on the AOMT podcast are those of the interviewers and interviewees and do not represent the official position of AOMT. The information presented should not be used as personal health care or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.